Welcome to Season 4 of My Wife the Dietitian, a fun, evidence-based weekly podcast about nutrition and healthy living. On today's show, we're joined by Dr. Dean Elbe for our first installment of Ask the Pharmacist. Dean tackles a variety of listeners' questions about food and drug interactions. Stick around as we Ask the Pharmacist. Enjoying the show? You can help others find it and enjoy it too by giving us a 5-star rating or review. If you feel like reaching out to us with a question or comment, you can send us an email at mywifetherd@gmail.com. And don't forget to visit our website at mywifethedietitian.com, as well as our social media pages. We're on Facebook, Instagram, and YouTube. Enjoy the show. Welcome to My Wife the Dietitian. Hello, Sandra.
Hi, Rob.
How's it going?
Good. How are you?
I'm doing well.
Good. We have a guest on again today.
Our pharmacist friend, Dean Elbe.
That's right. Ask the Pharmacist.
You got it.
We had an episode 178, Does Diet Affect Medication? With Dean. And this is a follow-up episode because it's a pretty hot topic.
Yeah, we thought when we spoke to Dean last time, we had so much fun and Dean enjoyed himself and he's such a wealth of knowledge that we thought we'd just do a regular thing with him, and we're calling it Ask the Pharmacist. It kind of makes sense.
Ask the Pharmacist.
Yeah, so we encourage people to send us your questions if there's things that you're curious about, medications you're taking, you're not sure if it's, about the interactions with food, and because there's all sorts of things.
And supplements.
In supplements, and it's constantly changing. And Dean's got a great resource that he created with the help of another dietitian.
It's called drugnutritioninteractions.com.
Exactly. And yeah, he references that quite a bit, and he's constantly working on that. And he's just, like I said, a wealth of information. So it's good to have him on here to sort of discuss some of the things that he's found in his research. And
he dove into his own research to answer these questions we got from listeners.
Mm-hmm. And what are we talking about today?
One question is regarding oral contraceptives and iron levels, and also what about vitamins and like B complex, and also another hormone issue around thyroid medication and the impact of eating soy foods or taking soy supplements and breast cancer risk. Yeah.
So like we say, I mean, if you've got like that, those are fairly specific questions. So if you have questions of your own, whatever they are, let us know and we'll fire them at Dean, and he can give you the in-depth review on whatever it is you're curious about. So stick around. We'll be right back with Dean Elbe.
Awesome. Well, we have Dean Elbe, pharmacist, back on the show because we had Dean a few weeks ago. Now, maybe actually a little bit more than that. But we did put it out to our listeners, like Ask the Pharmacist, do you have any questions? And we've got a few responses. And we wanted to bring Dean back on the show. And Dean, welcome back to My Wife the Dietitian.
Thanks, Sandra. Hey, Rob. Good to be back.
Hey. Yeah.
Awesome. Dean, just in case people haven't heard the original episode, which we're going to link in our show notes today, can you just tell us a little bit of your background just in terms of what you do and who you help?
Yeah, for sure. I'm a clinical pharmacist at BC Children's Hospital. I've been there since 2007, and I work with kids with mental illness. So I work in the child and adolescent mental health program, and I support all of our psychiatrists and nurses with medication-related questions, medication monitoring, consultation, etc., around medications for kids with mental illness.
Thank you. Yeah, no, that's great. And your wealth of information, all of the interns you have, and also all the physicians that are going through their training have to take some time with you, right?
Yeah, it's kind of neat. I've got a program where when I train pharmacy residents, I get a psychiatry resident in the child and adolescent psychiatry CAP program to come and spend a full month with me at the same time. So they sort of train each other together, and they work on their psychopharmacology skills. They get to focus just on the drug therapy instead of having to manage, every aspect of a child's care like they would normally do, right? Psychiatrists, I kind of view them as the quarterback for the team, taking all these inputs and managing all aspects. But they get to focus on psychopharmacology with me and do a bunch of extra. They get a lot of reps, so they see a lot of different drug therapies and handle drug information questions. They do all the things a clinical pharmacist would do, and they seem to love it.
Oh, I bet. And I mean, it would just be a great connection. Like you guys all learn from each other, I'm sure. And like the information is such a great exchange of information and collaboration.
Yeah, it really is. Like the pharmacy student is teaching them about different resources that they use and how to, literature evaluation and stuff like that. And the psychiatrist is there like on tap for 4 weeks for my pharmacy resident about here's the nuance of this diagnosis and we call it this, but if this happens, this has to happen for at least 2 weeks independent of another symptom to be able to call it this illness. So it's a great learning experience. It helps break down that, if there's a barrier of intimidation or whatever, right, of being afraid to approach a physician, that's gone because they've just spent 4 weeks with them.
Absolutely. They're probably having drinks by the end of it and just like hanging out socially.
I know a couple of these have stayed in touch. Yeah. So.
Oh, that's awesome. And the pharmacy students that you have, I guess they go off and be pharmacists in all different sectors of like with community and in hospital and cancer care and all of the different aspects of where pharmacies are.
Yeah. We mainly get pediatric pharmacy residents. So they're going to likely work at Children's Hospital or Surrey Memorial Hospital has a pediatric program. We occasionally get an adult resident. There are second-year mental health and substance use residencies now running. So we get a good variety of people through. But they go off and work usually in the hospital system after their 1 or 2 years of residency training is complete.
Awesome. Oh my goodness. Okay. Well, I have a first question from one of our listeners who is a young woman. Actually, a lot of our listeners are women. We do have some men too that listen to the show, especially if their wives are listening or their partners. And so you should listen to this episode.
They don't have a choice.
Yeah, that's right. Or they're on a road trip, and they put it on or whatever. But there's a lot of conversations I have with clients around hormones and, varying aspects of how hormones like changes through the life cycle and just different influences in the body and, weight and all those different things. And so this one is kind of, this is a younger woman. And she says, when taking birth control pills, are my iron levels affected? And what other nutrients and or medications may be influenced by taking oral birth control?
Okay. Well, first of all, just have to say, through our website, Drug Nutrition Interactions, it was a very helpful resource to me, even though I created it. It was a very helpful resource to me because actually, I don't work in this area. So I had to do a bit of research for some of these questions. And I found that, at least at the high level, these answers are in my website. So I was like, okay, good. This has been very helpful.
Yeah.
Yeah. So somebody else is coming to this website and they have questions about drug and nutrition interactions. They're going to find, likely going to find, just based on this small sampling of topics, that I was able to find, relevant information on all of these questions. So when taking birth control pills and in reference to iron levels, it depends kind of what your menstrual cycle was like before. So if it was very heavy with a lot of blood loss, actually regulating that menstrual cycle with oral contraceptive or hormonal contraceptives, or in some cases even suppressing it for long periods of time, like some people do take continuous hormonal contraceptives for many months in a row before having a withdrawal bleed. And that actually can lead to a decrease in blood loss and therefore an increase in iron, indirectly, I suppose. But and then as far as other recommendations, so our expert dietitian that provides the dietary recommendations in Drug Nutrition Interactions does recommend to consider increased dietary B vitamins like riboflavin, folate, pyridoxine, which is vitamin B6, as well as magnesium. So getting it from dietary sources if possible, rather than supplementation. There's also the aspect that a lot of the studies that were done that show these dietary changes or these nutrition changes were older studies that were done with contraceptives that had higher estrogen content. And sort of the different generations of third and fourth generation hormonal contraceptives tend to have lower estrogen content. Right. So perhaps the impact on these other vitamins may be somewhat less compared to older products with higher estrogen contents.
Oh, I see. Oh, that makes sense. And as you mentioned, I mean, a lot of women are having less of the blood loss because of the regulating effects of the oral contraceptives. So then if they were anemic or low iron prior, like if they had a heavier period and then they started taking contraceptive pills, then they're not losing as much blood. So they're not losing as much iron, basically. Yeah.
Yeah. And then there are some formulations that have supplemental iron, lowish dose, but there are some that you'll see an FE designation often, and that's got a low dose of iron in it each day as well.
I did not know that. Really? Like is it 28 day, like basically every single, even the placebo has the iron?
Usually the placebo has nothing.
Okay.
Yeah.
Okay.
So you have a 28-day formulation. There's more in the US than in Canada, but there's so many hormonal contraceptives. It was the worst. It was literally the worst entry in drug nutrition interactions. I think there were hundreds of formulations to enter between Canada and the US. Yeah.
What? Really? It's a big business.
Mm-hmm.
Big category. Well, it's also, you can't patent estrogen, so everybody can make one.
Oh, I didn't know that.
Really?
Yeah.
Like Jim's birth control pills kind of off the 7-Eleven shelves?
Kind of. I mean, ethinyl estradiol and, the various progestins are hormones. So you can patent your combination formulation, but to actually make ethinyl estradiol, everybody can make it. And it's easy to, obtain. So everybody and their dog has a different hormonal contraceptive formulation on the market.
Was it originally just like one kind of version, like one, like, because it seems to me, and I mean, I'm obviously not someone who's super familiar with this stuff, but even from my perspective, it seems like there's way more options for birth control nowadays than there was, say, 30 years ago.
Oh yeah. With different, different levels of the estrogen. Ethinyl estradiol is the usual one. And dropping, the trend is lower over time. And then the different progestins, there's 5 or 6 different progestins with, that confer different side effects. So sometimes the effect on acne and weight gain and things like that can be different with the different progestin. And now, of course, the move is to the hormonal intrauterine devices or IUDs. And that or the implant, those are becoming more and more popular as well.
Keeps you on your toes, hey? As far as all the interactions, that's a lot to, yeah. Are there other interactions that you've noticed, like when you were looking up the iron? Were there other sort of food or medication interactions that people need to be aware of with birth control?
I mean, certainly the hormonal effects, the effects on vitamin B, like riboflavin, folate, pyridoxine, magnesium. I think one of your other listeners had a question about, so I'll maybe segue to that, about B complex vitamins. There's an interesting one that they can cause vitamin B12 levels to go lower. But more recent research suggests that when you look at some of the other markers, this would be like MMA, which is methylmalonic acid, and homocysteine, which are associated with B12 function. When you look at those markers, they actually stayed normal. So overall, they've kind of said, your vitamin B12 level, if you measure it, might go down, but really your function of vitamin B12 is not affected by oral contraceptives. And again, the lower estrogen helps with that.
Right. Okay.
Yeah.
And I guess, I mean, in saying that, like whatever Rob said about like Jim's birth control pill or whatever on the market. So all of these are regulated by like Health Canada or FDA?
They are, yes.
Okay. So it's a little bit different.
Not over the counter.
Right. They're not over the counter. Okay. And I know a little bit of a tangent, but when we're looking at like prenatal vitamins, which is completely different than, hormone, contraceptives, but the regulation, do you know that, sorry, I'm kind of asking a question that we didn't prearrange here, but what about the regulation of like prenatal vitamin supplements?
If I recall correctly, those are typically available over the counter.
Yes.
So often they have like a combination of vitamins and then a fairly high folate, probably one of the most important prenatal vitamins.
Yes.
Has a fairly high level of folate in them. So folate works to prevent, among other things, neural tube defects and helps with blood formation. And so very important that pre-pregnancy or early in pregnancy that your folate levels are adequate.
Yes. Yeah, that's awesome. And I mean, that's the thing. If you're on oral contraceptives, then you likely won't get pregnant. But we also know that 50% of pregnancies are unplanned. So either people aren't taking their birth control pills, or they're not on them, or they're not taking, like they're not using a contraceptive. So having that, like even a multivitamin or just, a prenatal just in any woman that's like over the age of 15 would probably be prudent, because then the neural tube defect happens before you even know you're pregnant.
Right. Yeah, exactly. That's when that's forming, right? Early in pregnancy. So, we know that like the failure rate of oral contraceptives when they're taken perfectly is around 1%. Is the typical quote, but they're not always taken perfectly. Like doses get missed and things happen, and or they get stopped for a period of time, and so the failure rates are somewhat higher. So again, that's part of the popularity, I think, in the move to the hormonal intrauterine devices.
Yes, yeah, right. Because then it's just like, yeah, right. It's implanted. You don't have to think about it. It's just there. Yeah. Cool. Okay. Thank you so much. That's a really comprehensive, answer to that question. And I do have another one, and it's kind of a different, but it's kind of related to hormones again. So while on thyroid medications, do I have to watch how much soy in food or supplements? And if I do include soy, does this affect my breast cancer risk? This was another question from a listener.
Okay, so in some way the answer is simple, in some way it's complicated for this one. In the short term, while you're taking thyroid hormone, most commonly it's called levothyroxine. Soy and soy flour, soy-based products can decrease absorption of this thyroid hormone.
Okay.
So it's recommended to separate administration of this medication. Usually we say take it on an empty stomach, so it avoids all sort of foods 30 to 60 minutes before meals for that reason.
Okay.
Overall, like our dietitian recommends overall moderate dietary soy intake.
Okay.
Other foods that can decrease absorption include things like espresso, coffee, cottonseed meal, walnuts, high fiber foods can alter absorption. So just to avoid that, it's best it's taken on an empty stomach. Even in the hospitals, we schedule it at 10 a.m. rather than 8 a.m. with most morning medications for that reason.
Oh, okay. So separate the thyroid medication from food and with other medications.
Yeah, and like there's other medications that can bind it in the colon, so it's just best just take it separately if you can on an empty stomach. And then there's some evidence to say that high soy intake, because of this effect on absorption, can increase TSH and make your thyroid work harder. But there's some controversy about it. It suggests that, maybe while this is true, that there's limited clinical impact at the end of the day of high soy diets. So the other part of her question about soy affecting breast cancer risk is a bit harder to answer. So soy has these estrogen-like compounds in it called isoflavones,
Right.
and they have estrogen-like properties. They're not as strong as sort of natural hormonal endogenous estrogen that we release in our body. So we think that doesn't overall increase the risk of cancer. And there's some information that's newer that suggests that maybe it decreases the risk of breast cancer and other cancers.
Like protects.
Yeah. They say that, breast cancer risk is more affected by lifelong estrogen exposure, your genetics, other factors like alcohol consumption, weight, whether you've had pregnancies or not, can affect that risk. And this dietary exposure to soy probably doesn't change that compared to all these other factors. Now, if somebody has breast cancer or has a history of breast cancer or has been told they're very high risk, I would say talk to your doctor or your dietitian about this. It's a bit more complex decision, although recent studies again suggest that dietary soy decreases all-cause mortality, so deaths from any cause in breast cancer survivors. So research still evolving, a little bit of a complex interpretation.
Absolutely. Yeah, that makes sense. And that's what I often let people know that, moderate intake is kind of like 2 servings a day. So, especially if people are vegan or plant-based and they're having a lot of different tofu and tempeh and edamame and soy and, then maybe like soy milk, then maybe, watching maybe 2 to 3 servings a day and not using the supplement, like the isoflavone supplements that you can buy over the counter that's on the shelf, like the little capsules, because then you get like almost a pharmacological dose. Like it's a high dose instead of just in the food form.
Yeah. So I think moderate intake, and then I would agree that avoiding supplementation usually, right? Like I think that's a standard recommendation. If possible, get it from your diet.
Yeah, absolutely. Yeah, no, for sure. Yeah, wow. Rob, you've just been kind of a standby listener here. Any questions or interjections?
Well, with the soy, I didn't want to get into a huge tangent, but I know there's concern with soy and tofu and that whole thing, and it's a lot of what do we call them? Like the YouTube wellness kind of
like bro science
people. Yeah,
like
yeah.
Man boobs.
Well, yeah. I mean, there's a lot of people who completely won't even go in that direction because they equate soy with cancer, prostate cancer, breast cancer, whatever. And so is that kind of what you guys were just discussing? Is that right across the board as far as cancer risk, or does it differ with different types of cancer, or should everyone be afraid of soy or not afraid of soy, or what's your take on that?
Overall, you look at big organizations and they'll say that overall there's pretty much evidence that it doesn't seem to affect cancer risk.
Yeah.
There's evidence is stronger for certain things. There's limited evidence that says it may decrease the risk of lung cancer. They said there was evidence that all-cause mortality in breast cancer survivors was lower, but it's complicated, right? You have to do a big study for years and years and years of exposure, trying to control other variables as much as possible, or look back at large data sets that have been collected and look for evidence of soy intake, for example, and look for evidence of cancer incidence, and look back to try and determine, like, does this actually change your risk? But overall, you look at the American Cancer Institute for Cancer Research. Overall, they sort of said that it doesn't seem to increase risk for most cancers.
Yeah.
Good to know.
Yeah. And there's been in terms of some of the studies and like population data, like looking at ethnicities and with Asian cultures, a lot of their food intake, they do have some soy, like with tofu and other soy products and their risk of breast cancer is lower, but that's when they are basically having it since like growing up with that in their diet. So that might be a different like confounding factor in terms of women who don't have soy as part of their intake for decades and then maybe start to include more soy. So, what is that increasing their risk? Does it reduce their risk? Does it keep it? So like you said, like nutrition research is difficult because with food, it's really hard to do like controls and the randomized control trials where you don't really know what you're eating. Like it's easier to do pill form and placebo instead of food because people know like they're eating like certain foods, right? So it's tricky and it's hard to get people on a control diet for long term. That's the other thing. So
and it takes forever to get enough of these outcome measures to show a difference, right? It can take years and years and years.
Yes.
So often, like I say, you have to look back at data sets that are already collected and can you mine those data sets for this information with all the limitations that doing so provides. But sometimes that's all you've got because it's just not feasible to do the study otherwise.
Absolutely. Yeah. And that's a good place to kind of it's like we need more information. And you hear that in almost every research study that you read in journals. Like at the end, we need more information, more information.
Yeah, they always say it in child psychiatry. It's funny because I'm like, this is the information. There will be no more information. Here's the study. This is it, folks. So you'll get one trial and that's it. And for better or for worse, that's the evidence. So some of the bigger areas like this, it's good because it's of broad interest and somebody somewhere will do a study or they'll find a way to get the data because it affects so many people. But research is hard.
It sure is. Oh my gosh. Yeah. And then interpreting.
And that's why in trials that you'll see, they'll go for short-term outcomes, right? Like, I think we talked about metformin last time we were on as an anti-diabetic and the risk of using it for managing weight gain with certain medications. And you can study the change in weight over 6 or 8 weeks or whatever, 12 weeks or a year if you want. But the risk of, I would love to be able to say to some of my parents, can it reduce the risk of diabetes if you take this? Well, that's a 30-year study.
Yeah, right.
To get enough outcomes to know that it actually makes a difference. So it's looking at measures that can kind of be a proxy for what we really care about, but sometimes there's problems when you do that.
Yeah. And I always think back to, like in terms of medications in pregnancy, and I know they're way more safe and prudent because of like thalidomide and like just all of like the ramifications of women taking the thalidomide, which was like anti-nausea, I think, in the pregnancy, and then the effects of that on the fetus and, on the outcome of the child. So, I mean, it's like better safe than sorry, but at the same time, there's needs that people have and, medication that, we have to have trials. We have to have more science to see like what actually happens in different populations and, what the side effects are, what, the implications of taking certain things in certain populations.
I deal with questions like that sometimes with regard to especially antidepressant treatments.
Yes.
Through our reproductive mental health clinic, some of the psychiatrists that work there will consult me about risk and sort of evidence changes, right? Evidence is changing and new studies come out, but looking at what are the risks in a variety of areas, not just whether it's malformations or miscarriage or what about the risks of autism. Yes. So many what ifs, right? Yes. That are hard to answer. Yeah. And it's not ethical to do randomized controlled studies. So how do you get this information? It's kind of complex, but in a variety of areas, medications do sometimes need to be used during pregnancy.
Yeah.
And looking at what we know about them, but thalidomide for sure was a watershed moment, no doubt about it.
Do people bring that up sometimes with you?
No, it's kind of either recognized or it's so old now that it's just, this has become the system of how we evaluate medications in pregnancy.
Yeah, absolutely. No, that makes sense.
There's a couple of go-to resources for pregnancy and medications in lactation that we're thankful to have available to help answer these questions. Yeah.
Oh, yeah. No, that's
but,
awesome.
But new research is coming out too that suggests risk and different risks, and with exposure and things that aren't obvious, but maybe, over a big study, you can see an effect. So things are being raised, but it's hard to sort of prove that, yes, in fact, for sure, this is the cause. It's like, oh, there's an association. So what do you do with that information? You make the best decision you can with the information you have.
Yes. Yeah, that makes sense. Yeah. Absolutely. Wow, that's good. Okay. Rob, any questions that...
I'm going to save all my questions for next time.
Okay.
No, I'm just joking. That's a lot to take in. That was a pretty deep information, but it will all be clear once I often find, like, listening in the interview, I'm just like kind of like in a different mindset than when I am actually listening to it. Mm-hmm. And it all makes more sense once I can listen to it as a listener. Do you know what I mean? I'm just trying to stay on my toes and keep up with you guys when I'm doing the interview. So yeah, after I listen, then I'll have questions. So that's what I mean. Next time, I'll ask about this one.
Well, that's right. And I love this collaboration with Dean and Ask the Pharmacist. I think it's great because there's so many questions out there around food and medication interactions. And as Dean said, there's that resource, the DNI, can you say what it is again and where people can find you?
Yeah, it's Drug Nutrition Interactions. So www.drugnutritioninteractions.com. And it's a resource for professional dietitians and other healthcare professionals to get information about how food and nutrition interacts with medications in both directions. We've got over 1,100 medications in our database. And I did have at least one listener, Sandra. One listener called me about a billing issue, but she said she had just listened to our podcast and had made the decision to sign up for it. So that was great to hear.
Oh, great.
Awesome.
Oh, good. Yeah, I think it's so comprehensive, that drugnutritioninteractions.com. Like, it's incredible the work you've done. And it makes sense because, I mean, you're giving back to the world, and all of the decades of information you have and the work you did with dietitians since the beginning of your career. It just makes sense that it's available to people, and that, it's well used, I bet.
Mm-hmm. Yeah, it's great to see it's gathering steam. So that's good to hear.
Yeah.
And is it available for anyone? Like you said, for dietitians and health professionals, but it's not just for those people, right?
I mean, anybody can sign up.
Sure.
You will find the language is targeted for professionals. So just be aware of that going in.
Okay.
But anybody is open to sign up. You don't have to enter your credentials.
Sure. Okay. Yeah.
Absolutely.
Yeah. Good to know.
But to be able to make sense of the medical language in there is important. So.
Fair enough.
That's awesome. Oh, well, thank you so much, Dean. We really appreciate you coming back on the show, and we look forward to doing this again in the near future and having you back on for so many more questions, I'm sure.
Excellent. Great to have joined you again, Sandra and Rob. So thanks for having me on again.
Yeah, thanks again, Dean. We'll talk to you again.
Another great interview with Dean Elbe, pharmacist, on those different questions that listeners had.
Yeah, the man knows his stuff.
We really would love to have Dean back again, and we rely on our listeners to email us some questions, and once we get enough questions, we'll invite Dean back on the show and we'll ask the pharmacist.
Exactly. Yeah. So that is it for this week. If you want more information about what we are doing, or any information about health and nutrition, check out our website. We've got a great blog on there. We've got lots of different links. We've got a weekly newsletter you can subscribe to as well. That's free to join. You can email us your questions or questions for Dean if you have specific pharmaceutical related questions.
And check out his website.
Yes.
drugnutritioninteractions.com.
Perfect. You can also find us on social media. We're on Facebook, Instagram, and YouTube. Let us know how you like the show, too. You can rate and review. You can leave comments. All of those are super helpful for us, making sure you're getting what you want through this podcast. And share with your friends, too. I'm sure your friends would love to know if you're onto something new and fun, so that would be helpful for us as well. So we'll be back on Wednesday with our nutrition nuggets. So until then, have a great week, and thanks again for joining us. Thanks for joining us today on My Wife the Dietitian. If you like what you heard, don't be shy. Leave us a comment or review, and be sure to share our podcast with your friends. If you'd like to hear more, hit that subscribe button. You can also follow us on our social media pages for updates, episode trailers, and other odds and ends. For more info and links on what we discussed on today's episode, check the show notes. We'll be back next week with another informative and fun-filled episode.